Good day, and thank you for joining us. The Pain Therapy Unit at AOUI Verona, working under the supervision of Professor Schweiger, is pleased to present our experience with adipose tissue-derived mesenchymal stem cells, MSCs, focusing on their application in osteoarthritis and pain management. Adipose tissue is a complex endocrine organ composed primarily of two components: mature adipocytes, which are terminally differentiated and no longer divide, and the vascular stromal fraction, or VSF. The tissue secretes various regulatory proteins, including cytokines, chemokines, and adipokines such as leptin, adiponectin, and resistin. The vascular stromal fraction acts as a three-dimensional scaffold enveloped in a vascular network. Within this environment, cells communicate and modulate tissue regeneration. The VSF is composed of heterogeneous, undifferentiated mononucleated cells, including adipose-derived stem cells, hematopoietic stem cells, pericytes, endothelial cells, and exosomes, as well as extracellular matrix. Among the various cells within the VSF, mesenchymal stem cells, MSCs, are particularly relevant. These multipotent adult stem cells can differentiate into mesodermal lineages such as adipocytes, osteocytes, and chondrocytes. According to the International Society for Cellular Therapy, MSCs must meet several criteria: expression of specific surface markers, such as CD105, CD73, and CD90, lack of expression of hematopoietic markers including CD45, CD34, CD14 or CD11b, CD79 alpha or CD19, and HLA-DR, ability to adhere to plastic surfaces in culture, and capacity to differentiate in vitro into adipocytes, osteoblasts, and chondroblasts. MSCs have been isolated from a wide range of tissues, including bone marrow, adipose tissue, umbilical cord blood, amniotic fluid, peripheral blood, and fetal organs such as the liver, brain, and lungs. The tissue of origin significantly influences their biological behavior and clinical potential. Adipose-derived stem cells, ADSCs, are of particular interest due to their high yield. Approximately 2% of cells from lipoaspirate are ADSCs, compared to only 1 MSC per 25,000 to 100,000 cells in bone marrow aspirate. 1 gram of adipose tissue may contain up to 5,000 MSCs, around 500 times more than bone marrow. Beyond yield, adipose-derived MSCs offer practical advantages. They are easier to harvest, better tolerated by patients, and exhibit higher immunosuppressive potential than bone marrow-derived MSCs, depending on the therapeutic objective. MSCs possess several key properties that make them ideal for regenerative medicine. These include proliferation and differentiation capacity, the secretion of multiple bioactive molecules via paracrine signaling, and immunomodulatory functions. The multipotent nature of MSCs enables them to differentiate into various lineages, including osteogenic, chondrogenic, adipogenic, myogenic, and tenogenic pathways. Moreover, they exhibit a homing ability, migrating towards injured or inflamed tissues in response to chemotactic signals, thereby contributing to tissue repair. MSCs also exert significant paracrine effects by secreting a broad array of soluble factors. These include exosomes and growth factors that support cell viability, promote proliferation, stimulate angiogenesis, and aid tissue regeneration. Such effects also play a role in modulating immune responses and maintaining tissue homeostasis. MSCs contribute to angiogenesis through interactions between pericytes and endothelial cells. Their secretome also exerts anti-inflammatory and antifibrotic effects, inhibits apoptosis, and encourages adipogenesis. Furthermore, MSCs have shown antimicrobial and immunomodulatory properties, reinforcing their role in tissue repair. The immunomodulatory function of MSCs is highly dependent on their surrounding microenvironment. Inflammatory cytokines and hypoxic signals can influence MSC behavior. Depending on the context, MSCs can either enhance or suppress immune responses by releasing specific immunoregulatory molecules. Once stimulated, MSCs adapt to the physiological environment. They may secrete factors that promote immune suppression, for example, by inhibiting macrophage activation via T regulatory cells, or factors that enhance immune responses. This adaptive behavior is critical to their therapeutic potential. To preserve the viability and functionality of MSCs, the processing of adipose tissue must minimize cellular stress. This includes avoiding centrifugation, which can induce apoptosis due to excessive gravitational forces or vacuum pressure. Instead, gentle methods such as continuous washing and microfragmentation are recommended. Studies show that centrifugation, especially at high speeds, significantly reduces cell viability. In contrast, decantation at low vacuum pressure, followed by continuous washing, ensures better cell preservation and higher quality MSC yields. Continuous washing is essential for removing residual lidocaine, which has been shown to reduce adipocyte viability by up to 60%. This step also eliminates other pro-inflammatory elements, such as blood and oil, purifying the tissue before implantation. Fragmenting adipose tissue into small clusters, approximately 1,000 microns, improves stromal vascular fraction exposure, increases cell viability, and reduces cell death caused by loss of adhesion signals, a process known as anoikis. Different fat preparations offer varying degrees of viability and stromal content. Microfat, at around 1,200 microns, maintains high adipocyte viability and stromal content. In contrast, nanofat, generated through mechanical emulsification to about 600 microns, shows significantly lower viability. Macrofat, around 2,400 microns, also maintains good viability but offers lower SVF exposure. In osteoarthritis, MSCs may act through both direct and indirect mechanisms. Directly, they can differentiate into cartilage tissue. Indirectly, they stimulate chondrocyte proliferation or promote endogenous stem cell recruitment within the joint. Recent studies also suggest potential therapeutic targets involving mitochondrial dysfunction and MSC senescence. Although the number of studies evaluating the effects of ADSCs on pain is limited, this may be due to the difficulty in assessing pain in animal models and the complex nature of pain itself. Nonetheless, current evidence suggests that ADSCs have significant anti-inflammatory and immunomodulatory properties and can attenuate specific pain pathways through exosome-derived microRNAs and other paracrine factors. We conducted a prospective observational study from April to December 2024. Our objective was to evaluate the efficacy and safety of intra-articular injections of adipose-derived tissue in patients with knee osteoarthritis who had not responded to conservative or minimally invasive treatments. Inclusion criteria required the presence of knee osteoarthritis resistant to previous therapies. Patients were excluded in cases of sepsis or local infection, ongoing or past malignancy, or lack of informed consent. Our primary endpoints included pain reduction, assessed using the Visual Analog Scale, VAS, and improvements in quality of life, measured by the Oswestry Disability Index, ODI, and a general COEL scale at baseline, 1 month and 3 months. The secondary endpoints focused on tolerability and safety, evaluated through adverse event reporting. The study included 22 patients with knee osteoarthritis, 13 women and 9 men, with a mean age of 68 plus, or minus 14 years. We performed 11 unilateral and 11 bilateral procedures. Baseline scores were as follows: VAS, 80, ODI, 66.5%, and COL 42.5. Each patient received a single intra-articular injection of processed adipose-derived tissue. Follow-up was conducted through phone interviews and clinical evaluations at 1 and 3 months after the procedure. The LipoStem DUO kit was used for all procedures. This included a 16G cannula for Klein solution injection, a 13G cannula for liposuction, various syringes for infusion, an infusion line, clamps, Lua caps, and a dedicated processing bag with integrated waste bag. Adipose tissue was harvested via small volume liposuction, preferably from the abdominal region. Other suitable areas included the gluteal and thigh regions. Klein's solution was infiltrated using a 16G cannula, and after waiting 7 to 8 minutes, lipoaspiration was performed using a 13G cannula. A compressive dressing was applied for 48 hours to minimize bruising. The Klein solution was prepared using 20 milliliters of 2% lidocaine for analgesia, 0.5 milliliters of 1 milligram per milliliter adrenaline to reduce bleeding, and 250 milliliters of saline solution. A standard infiltration to liposuction ratio of 3:1 was applied, although adjustments were made based on physician preference. The harvested adipose tissue was inserted into the lipoion valve of the processing bag. Continuous washing with saline was performed to eliminate impurities. Mechanical agitation with a spatula facilitated purification. Once the tissue reached a pale yellow color, it was collected from the lipo-out valve and prepared for injection. The adipose tissue is processed entirely within the closed system of the LipoStem DUO. After inserting the lipoaspirate through the lipoion valve, approximately 150 milliliters of saline solution is added through the infusion line. The waste clamp is opened to eliminate impurities, while a spatula is used to gently move the tissue. When the fat becomes pale yellow and the tubing turns clear, the processed tissue is collected from the lipo-out valve. Importantly, this method avoids the use of centrifugation or enzymatic treatment, ensuring minimal manipulation. Light mechanical forces preserve the architecture of cells and the extracellular matrix, maintaining their trophic and anti-inflammatory properties. Continuous washing further eliminates pro-inflammatory components such as blood, oil, and remnants of Klein's solution. The system includes 2 filters. The first, with a 1,000 micron mesh, microfragments the adipose tissue. The second, with a 51 micron mesh, removes blood and oily residues while retaining the purified, microfragmented tissue. This final product is then ready for clinical use. The processed adipose tissue is injected into the target joint. The volume used varies depending on the joint and patient characteristics. In our study, the average volume was between 7 and 9 milliliters. No immobilization or rehabilitation was required after the injection, and patients were allowed to mobilize immediately. Regarding the primary endpoint, we observed a clear reduction in pain, disability, and improvement in quality of life. ODI and COL scores began improving after the first month, while VAS scores showed significant improvement starting from the 3rd month. As for safety, intraprocedural discomfort was reported in 12 patients during adipose tissue harvesting and in 6 patients during injection. No adverse reactions were recorded either immediately after the procedure or during follow-up. In conclusion, our experience suggests that the intra-articular use of autologous MSCs is a simple, minimally invasive, and low-risk procedure. It led to pain reduction, improved function, and better quality of life over a 3-month period, with no major complications. A systematic review published in 2022 analyzed 10 studies, including 6 randomized controlled trials, with a total of 699 participants. Most used autologous MSCs, though 2 used allogeneic cells. The findings support the safety and efficacy of MSCs in osteoarthritis treatment, despite variations in cell types and control groups. Another study evaluated the durability of Master of Science effects over time. It reported sustained clinical improvements and no radiological degeneration up to 5 years after injection. Additionally, signs of structural joint remodeling were observed up to 3 years post-treatment. In light of the evidence from both our clinical experience and the literature, we believe that adipose-derived mesenchymal stem cells represent a promising and practical therapeutic tool for the treatment of osteoarthritis. This approach combines biological efficacy with procedural simplicity and safety. Although further studies with larger patient populations and longer follow-up periods are needed to confirm these findings, the preliminary results are certainly encouraging. We are optimistic about the future role of MSCs in regenerative pain medicine. Thank you for your attention. We welcome any questions or insights you may have, and we look forward to hearing about your own clinical experiences with regenerative treatments.